started for today's patient-centered HIV care model demonstration project, our monthly call with all of our fabulous sites around the country. I would like to ask folks if you could please mute your lines as we start the process, and as you have a conversation that you, if you want to contribute to the conversation, please, chime in at any point in time. But I know there gets to be a lot of background noise that folks have been experiencing when they log in to the call. Today's agenda, we just wanted to provide a recruitment update for you, review and discuss the recruitment and retention action plans that have been developed with each site, provide you with some data that has been initially collected for the project. Again, review quality assurance, talk about patient demographic forms and the quarterly patient information forms. Kristen is going to chime in and talk to us about the abstract that's going to be presented in Miami at the end of the month, and I want to discuss site visits with you as well. So first of all, I would love to congratulate Albany Primary Healthcare for all their fantastic work. They have, as of yesterday, reached 100 patients enrolled in the project. So congratulations, Terry, Clifton, and Ashley, and the rest of your team. You guys have done a tremendous job in getting folks into the project. So congratulations. I would also like to say that since the expansion or the extension of the recruitment deadline, I want to really say thank you to all the sites who have done a tremendous job over the last 2 weeks enrolling folks into the project, and for our pharmacists on completing forms, the CMRs as well. This has been, I know, a tough project in many locations to recruit individuals into the project, but you guys have done a tremendous job, almost doubling the amount of individuals recruited into the project in the last 3 weeks. So that is absolutely fantastic. If we look at our recruitment site enrollment progress chart, all of our bands are slowly increasing across all of our 10 sites. As you see, Albany, which is our first site, has reached that 100, and I'm told that they're going to keep going. Is that right, Terry?
We will keep enrolling folks as we have patients that want to do that, yes.
Awesome. Fantastic. Absolutely fantastic. So thank you for that. And again, thank you for all of your tremendous progress. We have great progress occurring across all the sites. And it looks to me like our next 2 sites will probably be Truman and Southampton as reaching their goals, because they are really getting close to that area, as well as Howard Brown, who has tipped over the halfway mark for their project, as well as Mazzoni. I'm sorry about that. I did want to put up the referred and scheduled appointments from all of the sites from last week, and the data that we have received from individuals. This basically shows the number of people that you have referred to the pharmacy for MTM services and the scheduled appointments that have been scheduled with the pharmacy to be completed. So we're really working toward reaching our goals and objectives. So congratulations. I wanted to just indicate that we are shooting for this June 30th deadline. We were lucky to get the additional month of recruitment, but we are really focused on June 30th as the final enrollment into the project, and we want you to continue to really push over the next month or the next 3 weeks to hit that June 30th target with as many patients as you can enroll in the project. I did want to take a moment to talk about the recruitment and retention action plans that each of the sites have worked on developing and reviewing with Michael DeMeo and project team members on the site-specific calls each week. And I just wanted each of our sites, if you could talk to me a little bit, or talk to us a little bit about your recruitment plan and what change have you implemented in the project in order to reach your recruitment goal. I know that Albany is already reached their goal, so if unless Terry or Clifton have a comment at this point, I'll jump on to the next site.
No, I think what we have is working. So, Terry, correct me if I'm wrong, that we're just going to keep doing what we're doing.
Yeah, we don't have anything new and exciting to add at this point.
Terrific. Great. Care resource? Any new and exciting thing?
It's me, Linda.
Oh, hi, Linda.
Hi. What we've done is actually we've gotten all the numbers from and clients from the medical part that do have insurance and are getting care here and are getting their meds from Walgreens, and that's been working pretty well for me. I have 6 pending appointments this week set up for Angela, and we have 14 pending within the month, so we're pretty good.
That's awesome. Mm-hmm. That's terrific. Thank you for that update.
Well, it's been working very well this way.
That's great. So looking at the insurance and who's getting their medications from Walgreens is a good success. Terrific.
Yep.
Is anybody from Broward on the call? I mean, I'm sorry, from Miami location on the call? I know I see Jason has joined. Any changes for that site? Okay. We might not have people connected to voice yet. Truman.
Hi, this is Rose. So for the last, 2 or 3 weeks, we've had great success with actually calling the pharmacist when we have either a patient that we have previously referred and they've had trouble contacting, that when they come in for their clinic appointment, they come up and see them in the clinic. Or they also have come up and seen patients, their new referrals, like within 5 minutes.
Oh, that's great. So you are really syncing the patient being present in the clinic with the initial CMR.
Yeah. And we also have used, had one of the pharmacists come up and sit with one of our peer educators and she's contacted patients they've had trouble contacting by phone, and they've been able then to do the CMR over the phone with them then.
Oh, great. So is that occurring? So the peer educator calls the client and the pharmacist
talks to them about how they've been referred through that, and if there's any other information they want to share with them, and then they hand the phone over if the patient's willing to talk to the pharmacist.
Oh, that's great. Great idea. How Chad and Jean, how's that been working for you?
It's been absolutely fantastic. With the peer educator, it was wonderful because she usually contacts these patients for fun things like lunches or dinners or special fun things. So they will pick up her phone, but they might not pick up from ours or...
Well, and because they're at work.
Yes, and that's something that we learned. So that has been really helpful. To have me or one of the pharmacists right there so that we can take the call while they're still engaged has been really, really good. And what we did discover is some of these folks that were really hard to reach, the reason that they were hard to reach is because they are working and their working shifts basically match when our pharmacy is open. So that would explain why we might not be able to get in touch with them. And then having the clinic call us and us being able to go up and meet with the patients has been really wonderful. I've been working with one particular provider this week, and I think we recruited and I was able to do a CMR on every single one of the patients that she saw yesterday.
Oh, that's great.
Yeah,
absolutely
one of the
fantastic
benefits of that is that one of the patients is hearing impaired, and so while we had the translator that was there for the healthcare visit, then I could also utilize the translator to do what I needed to do as well.
That is fantastic. Great update, and kudos for both you, Jean, and Chad for your flexibility in being able to go up on the floor and really connect with clients. Thank you.
You're welcome. It's great.
That's awesome. Mazzoni.
Hi, this is Andrew from Mazzoni. So we've been using a lot of the same strategies for finding patients. Also, recently we've decided to, go back and review a list of patients, like run a query with our EMR and identify patients that we haven't seen in 6 months or so, and try to, very diligently reach out to them and get them in for an appointment, or even get in touch with them, interview them on the phone if necessary.
Terrific. So that's kind of a new approach for you, doing the interviews on the phone?
The list. Since it's been about, since we've been working on this project for 6 months, it's with fresh eyes, maybe going back and trying to identify some of those patients that maybe we tried to reach out to before, or maybe said no before, things like that.
Awesome. Awesome. Thank you. Anybody from Beth Israel join us? Okay. Howard Brown.
Hi, this is Diane. Our biggest change to the plan was actually taking a number of folks that were in our referred column and really trying to figure out if those people were going to follow through, after a number of contacts. We ended up moving a bunch of people from referred to refused after looking at it and being like, that's just not a good use of our resources right now. So working with the pharmacist, we identified those people that, have just been lingering in the referred for months and have not followed up, and we've decided that, after a certain number of contacts, they were going to be moved over. So we could really focus the resources on getting to the folks that have been more communicative and more engaged in the project. And then other than that, we've been continuing getting referrals from the pharmacist, from the clinic, from case management, all of those And then also our pharmacists, because we're focusing our resources in that way, are really doing a great job of scheduling the MTM appointments really close, if not the same day, then a few days afterwards, after they've been referred. So that's been successful.
Terrific. Thank you very much. Anybody from Desert AIDS join us? Okay. Tracy, Unity.
We also have been taking advantage of clients that are stopping by maybe just to say hello or in the clinic, and being able to call and work with Heather, our pharmacist, in real time. So that's been extremely helpful. And I'll let Heather speak for some of the changes they've made within the pharmacy. So Heather, did you want to share some of the changes?
Sure. Michael, we have been, so my team has also been on the lookout, so as patients with these certain providers from this clinic are filling their medications through the workbench, we have created a tag that we label the bags that we speak to the patient about the project when they ring up at the system. And if they're very interested, then my team will get me, we'll talk to them. If it's something we can get a hold of Tracy to get the enrollment going then and do the CMR at that moment, we will. If not, we'll tell them we'll be in contact about getting them enrolled. So we're using our actual workbench for recruitment. We are also using, we're running reports on patients who are already currently enrolled to double check to see if they are a candidate for enrollment, and Tracy and I are touching base that way to look at the different patients already here. And then lastly, we are looking at a current pharmacy that's closing in the area and seeing if there are patients that are currently using that pharmacy that could possibly transfer over here. That might be a good partnership that way.
That's great. Awesome. Thank you both for that update. Terrific. Southampton.
So we're pretty much using the same models we have been working with the pharmacy. However, what we have been doing is the pharmacy's actually been printing a list of our patients out for the day, and they've been contacting them that way as well if we missed over any, and then as soon as they pick up their meds, they do the CMR right there with the patient.
That's terrific. Awesome. And you guys have been on a roll as well. So great strategy and implementation happening there. So thank you. Any other comments that people would like to make about the recruitment and retention action plans? It sounds like they have been helpful in some ways. Or not?
Yes, it's been helpful.
Okay. So I wanted to walk through some initial data. Patrick, did you want to go through these two slides, or do you want me to do that?
I will give you the honor, sir.
Terrific. Kathy Berg, our CDC project officer, recently provided a project update to the leadership of CDC regarding the project. And some of the initial data we wanted to share with you that I found interesting from the slide decks. I pulled two slides here for you. The first one was showing the enrollment and participant demographic data of the first 101 participants that have been enrolled in the project. So you see our median age is around 46 years of age, 64% male, 32% female, 70% were categorized as Black, and 39% had less than a high school education. We do see from those first 101 patients that their household income was less than $15,000 per year. The 61% indicated they were unemployed at the time of enrollment, or they were categorized as unemployed at that time. And as far as a breakdown of insurance plans, we had just about 60% of people that were enrolled or had access to Medicaid in order to receive services at the clinic. And Ryan White Provider, or ADAPT, came in at 21% of that particular population. So there are so this data is just kind of a snapshot in time, and we will be updating this as we go along, and more of the forms are being analyzed and the data entered. We do currently have, as of May 20th, when this presentation was produced, we did have 350 completed CMRs in the system, meaning that we have received documentation of those CMRs occurring. So that just gives you a little bit of a snapshot there on the project. Additionally, Walgreens contributed this slide, which I found very interesting as well. This was looking at HIV, looking at the HIV drugs in relation to other comorbidities that the patient had, and this was looking backwards on fulfillment data from August 2014 through March of 2015. As you can see that we have on this graph that this is looking at the female participants, 75 female participants. Their average age was around 48 years of age, and you see that 67% had HIV fulfillment data that was available, meaning that they were that those 67% of folks were actually getting their medications through Walgreens. 67 of the 75 were getting their medications through Walgreens. The additional individuals, the other 23%, were getting their medications elsewhere prior to the project. And this just gives you a description of the top-level medications that the patients are currently, the conditions for which they are receiving medications. Any questions on the data? This is just a snapshot, again, based on that initial data set that was pulled for the patients. So we will be looking at that fulfillment data, and in a few minutes we'll go back and we can talk about how that may be able to help the clinical providers when they're providing follow-up visits with the patient regarding adherence.
Hang on, Michael.
Oh, yes, sir.
Yeah, I just wanted to, again, reemphasize the fact that we're providing this because it is an incredibly global, generic overview, and it's just a snapshot, just in this one. We want you to start thinking about your own questions that you have, because we are going to have a very, very rich data set and you may want to have a question asked about a particular type of population that you're serving, a particular disease state, anything along those lines, and that's what we can go into this database and begin to look at for you so that you can see how you are doing with those patients, maybe at your site compared to the other sites on the project. We can talk about this going forward, but this is some of the things we want you to begin thinking about now that the end of recruitment is in sight, and you all can see that. Now we can start thinking about what's the use, what can we actually gain from this to help better serve our patients.
Thanks, Patrick. Any other questions or comments? Right. I just wanted to touch on quality assurance of the data that we have been receiving. I would like to stress to be sure to write legibly on when you're completing forms. And it has come to our attention that it is best when people utilize a pen in filling out the form versus a pencil because it comes through better when the forms are either scanned or they are faxed to us. I would like to just revisit to make sure that individuals, you have been doing a great job putting the dates on the forms of when they are submitted and filled out. And additionally, in the follow-up sections of the initial patient information form, talking about the patient's next scheduled medical appointment and the first scheduled MTM appointment. Putting those dates also on those forms. So that has improved greatly since our last call. Any questions around quality assurance? And I would encourage folks, I know that as the pharmacists transitioned to a new process for conducting the CMRs and TMRs, I do want to encourage you that as soon as you have forms completed and you get back that CMR from the pharmacist, please send that over to us right away so that we can start the quality assurance process and the data entry on our side of the project. You guys have also been doing a great job of putting one form per fax. That allows us to really be able to easily track the forms when they're in the system, and again, attaching no cover sheets to those forms. One of the things as we have identified as we have gone through the forms that have been submitted was the patient demographics form. And this is the single page that is completed for participants who decline, or patients that decline to participate in the project. I just want to remind people of that form to please send those over to us. We're really looking to create a profile of the individuals who decline participation in the project. This data is basically the same data that is initially collected for patients who are enrolled in the project, but it goes no farther than this. So this is like page 2 of the patient information, page 3 of the patient information form. But this is a specific form that you have that we would like you to complete for participants who decline participation. Any questions about that?
No.
Yeah.
Okay. You have
Michael?
a question? Yes.
Yes. So, you know, just talking about, like, if they decline, I've had people that, you know, just really didn't want to share any further information. Is that something, you know, you're suggesting to go into the chart to obtain, or?
All of this information should be obtained from the chart,
right.
not through a patient interview.
Okay.
And if it's able to be obtained, complete it. Complete as much as you can
right.
on the form. So if it's sex and race, ethnicity, if that's
right.
all you're able to complete, complete those sections.
Okay. Yeah, because sometimes it's not really documented well. Sometimes it is.
Yep.
Okay.
Great point. Great point. And when you send these over, you can send these over to us in groups. You don't have to send them one at a time for this particular form, because that would be very challenging to do.
And Michael, would you do those in dates, kind of like weekly, as we have submitted the weekly reports?
Whatever is easiest for you to do for this particular form.
Okay.
But the initial patient information form should be sent to us right after you get the CMR or CMR paperwork back from the pharmacist.
It might be simplest to send it on the same basis. That way, since it's fresh in your mind of the people that had declined participation. But there was a call, I think, yesterday that someone was asking about their rock star patients who didn't necessarily want to qualify for it. And, those kind of people that maybe they would or would not want to participate. That's perfectly fine. If you've approached them and they said they didn't want to participate because they think everything is going fine with their disease state, then just complete this form on them and then just send that in.
Okay, thank you.
I know that we have a number of participants that are enrolled in the project now that it is time or past time for their quarterly patient information forms to be completed. And this works a little differently than the initial patient information form, and I wanted to take the opportunity to really walk through that with you so that we have some clarity. I know there's been several questions that have been emerging about it. So the quarterly patient information form is completed every 90 days from the date the person enrolled in the project. And that quarterly patient information form should only contain the data that has been placed in the medical record since the initial patient information form or the quarterly data sheet was submitted in the project. We do not and we cannot accept quarterly data that is submitted to us on the initial patient information sheet. We will send those back to you because there are different questions that are being asked on the quarterly patient information form. Just as a reminder, submission and acceptance of those quarterly patient information forms, that is what triggers additional payments to the health center. So each of our health centers that are enrolled in the project had an initial funds that they were given to enroll those first batch of clients, and that is the number of clients that the site elected to select as their target goal, and additional payments are then based off those quarterly forms. So I just wanted to remind folks of our expectations in the project is that, and all of you have demonstrated this, scheduling appointments, with the patients at least once every 6 months. You're going to obtain that medical information only from the medical record that is going to be put on that quarterly information form. This is where there is a change in the process, this next piece. So once you complete that quarterly information form for a patient, they've reached that 90-day mark, you will complete the quarterly form and you will send that to the pharmacy, provide that form to this pharmacy. You will also immediately send that form to Health HIV minus that page 2, which contains that personal health, private health information on it. So once a quarterly form is completed, it goes immediately to the pharmacy and to Health HIV. There is not waiting for any waiting time for the pharmacist to return TMR or targeted medication records to you. Does that make sense?
Yes, got it.
Okay. That was
perfect.
Hey
everyone, this is Ambrose from Walgreens. Thanks for that overview, Michael. I just want to chime in here. You know, I know we changed the project model a little bit in terms of the CMR, where we would meet with the patient first and then get some of this data later. For the TMRs, it's going to be really important for us to have this information ahead of the appointment if possible, because it's really going to help shape the follow-up TMRs that we have with the patients and the discussions that we have with the patient. You know, the CMR we can do sometimes without having this information handy, because a big portion of the CMR for us as pharmacists is to get to know the patient and build a relationship with the patient. And of course, we'll continue to do that throughout the TMRs, but having the data is really going to help us as we have those discussions. So thank you.
Thanks, Ambrose, for that additional information. So I did want to just demonstrate to you how this how this is envisioned to work.
Michael.
So if you and, I'm sorry?
Michael.
Yes.
Hey, this is Terry in Albany. I just want to ask you one question before you move forward. Will you send a clean copy of that quarterly report out like you sent a clean copy of the initial PIF?
Thank you, yes.
Yes, I can.
Agree.
I can send that out to everyone. Yes.
Thank you.
And if you do need, I know that as copies get, you know, used or you need additional materials as far as you need a new copy of something for clarity, please do ask us and we can send those right over to you. So I will send those out to everyone following the call today.
Thank you.
You're very welcome. So we have a patient 005 that was enrolled into the project. That means they completed their CMR and the clinic has received that CMR back from the pharmacist, and that happened on January the 2nd. So on April 2nd, which is 90 days, about 90 days from that point, you should automatically be completing a quarterly information sheet on the patient. This would be completed even if the patient has not come in to the clinic. So on the first page of the quarterly information sheet, there is documentation which asks you if the client has been in to the clinic, if they have seen a provider for any reason, if they've had lab work done in that time, and if in fact they have not been to the clinic, then you document below. There are about 10 choices and a write-in choice on why they have not been to the clinic. That gets, again, faxed to both the pharmacy and to Health HIV. If the patient was in the clinic or had seen a doctor, then that medical information, the documentation that had been supplied in the medical record since the last time that CMR was, the last time that form was completed, that is the information that needs to go on the quarterly information sheet. Just that information. I know, Terry, you have completed a bunch of quarterly forms right now. Can you tell us, is it faster? Can you tell us a little about that?
It does not take me as long to fill out the quarterly report as it did the IPS. I think that, and it's one of those things, too, that once you get used to it, you move a little faster through it, once you get used to kind of knowing what information what's going to be asked for on it. So, yeah, it's still a little lengthy to me, but, we've had a discussion around that, and there's going to be a lot of white space on there for most of your patients. Because a lot of times they've just only had maybe, most of my folks have had one, maybe two visits with us. There's just not a lot of data to really send you. One thing I have found useful, though, and I'll just stick this in while we're talking about it, is what I started doing, like with the initial form, when you sent us that clean copy, that attachment, I just saved it to my computer. And every time I had a new patient, I went in and just edited the header to put in that patient's number and our ID and stuff, and then saved that and printed it out. And that way I had a clean form printed out for that patient, and it already had their patient ID and the site ID on it, and just not having to write that on 20 pages is a time saving.
Right.
And so I'm going to do the same thing with the quarterly. Just that little bit helps. Great
feedback. So does everyone understand the process of how that is going to be documented, or when forms are due?
So, Michael, so I understand, after it's filled out and sent to the pharmacy, then you said it goes directly to Health HIV?
HIV. That is correct.
Okay, so we don't wait for anything back from pharmacy. So we initiate this and sort of drive this part of it.
That is correct.
Okay.
That is correct. The quarterly form does have a section on it that asks you about feedback from the pharmacy.
Okay.
So it asks you if, when you sent the last form to the pharmacy, when the pharmacy sent back their reporting to you, and did the provider respond to the TMR forms. So it does ask you that on the quarterly form. So that is a mechanism that we will utilize to determine, where we're missing forms or where there's gaps in forms between the clinic and the pharmacy.
And if I may, is it the first one would be referring to the MTM, or you said TMR? Like if the doctor saw the MTM?
Yeah, it's the MTM form. Right.
Okay.
Yes.
Got it. Sorry.
No, that's great. A lot of terminology, and sorry I used that. So just to remind you, some mechanisms that you can really optimize the model is that when you have a patient that is having an upcoming appointment, to notify the pharmacy of that appointment, provide them with their last date, the last date of the appointment that they had. The pharmacist will be able to provide you and be able to calculate some adherence rate data for you that can be used during the clinic visit for you to talk with your patients about if they're having adherence issues. This is also an opportunity for the clinic and the pharmacy to really synchronize those TMR visits or those quarterly visits with the pharmacist. We do expect the clinic to help coordinate the visit with the pharmacy. So if we have challenges, just like we heard from Truman as they're having the health navigator or the peer educator call clients to come in, we do want the clinic to help support the pharmacy in getting that patient back for their TMR visit. Any questions? Awesome. As for the pharmacist, once you get that TMR form, and once you get the form, we would like for you to schedule that TMR visit with the client or work with the clinic in coordinating that visit. You have already provided the clinic through your initial CMR visit the active medication list and any medication action plans that were developed. We are asking that you document on your forms whether or not you have received a response from the medical provider or the medical provider has approved your suggestions or recommendations. And we anticipate every 90 days, about 90 days, we're not, 100% strict that it's 91 days, it's not counted in that quarter. Every 90 days, we would like to have a visit, a call, an update on the patient since their previous visit. So doing any follow-up on your CMRs or TMRs. Ashley, not to pick on Albany and the Albany site, but you have done a number of TMRs as well. Any recommendations or any challenges that you have experienced?
Our main challenge with the TMRs, which is some of our challenge with doing the CMRs, is just trying to get in touch with the people and get them back in a timely manner. But if a lot of my TMRs, I do have issues, of course, new issues with my TMRs, but on a lot of my TMRs, if there's not really, like Ms. Terry said, there's not really a lot of information on the sheets and everything is going well and there's not really anything new, then I'll do those over the phone. So I can kind of get those in. It's just the ones that have the problems trying to get those in where I really would like to do the face-to-face. But the TMRs are going a lot faster than the CMRs because we've already developed a relationship. We already, know a lot about the patient and what's going on. So.
One of the things I want to make sure everyone remembers is the #1 outcome of this project is maintaining the engagement and care and retaining people in care. And if you're reaching out and you're touching and you're making contact with them, that counts. Believe me, that is going to make a difference. And that's what we're hoping we're able to show at the end of this project is compared to historical rates, now for people that participate in this project, what was our retention and care rate?
Terrific. And I just wanted to touch base with Jean and Chad. You have done a number of TMRs as well. What has your experience been?
Positive.
Okay.
Yeah, we have recently put the TMRs a little bit on hold since we've been working on so much on getting these patients recruited and enrolled with the CMRs. When we are doing our TMRs, they have been pretty beneficial. I feel like we do a lot of TMRs, even if they're not official ones, because these patients come in again and again and again.
Terrific. And Sayari, you have done a number of TMRs as well. From Mazzoni, how has that been?
What was the question?
Hello?
Oh, you have done a number of TMRs visits. Has that been challenging for you, or what has that experience been like?
No, I haven't done one recently. No TMR, not
right.
TMR. It's a lot easier. However, I've been trying to do TMRs a little earlier than 3 months because since because we were kind of rushing to register patients. So I feel that I needed to do the TMR a little earlier than 3 months. Is that okay? So I'm going to start doing earlier TMRs. Not that earlier, but a little earlier so that I could catch up with the patient.
Mm-hmm.
So this is Ambrose. Sayori, that's a good question. You know, the goal for TMRs is to try and do it, you know, around 3 months. Obviously, we know we're not going to hit the exact 3-month mark on the dot, but that's just kind of a reference point. We should try and stay on schedule and do one each quarter. So let's say for that situation that Michael put up on the screen with the dates, you know, if we did a CMR in January, you know, we would want to try and deliver that first TMR towards the end of March, beginning of April, and then try and stay on the every 3 months from that initial CMR date. If a patient were to miss an appointment or have to reschedule, so let's say that first quarter TMR didn't happen until June 1st, we would still want to try and have another TMR in July, even though that second TMR.
Yeah, okay. So because for the most part, I'm meeting the patient again the next month.
Yeah, so, you know, if we are late on a TMR, we want to try and stay on that 3-month schedule if we can, realizing that if we did a TMR for this patient here in June and then had another one scheduled for July, that second one would be more of a follow-up visit.
Okay.
But we still want to count that as a TMR and make sure we're following up with that patient when scheduled. And like I said, it's a target date. You know, we want to try and keep it within 3 months. It's better to do it a few days early or a few weeks early than late, I would say. Okay. So if you're doing it a little bit early, Siri, that's fine.
Yeah, we do want to keep it around that 3-month period of time. But if you see the patient as a follow-up, and you want to submit a form, by all means, I don't see that being a problem. The clinic, however, will only required to supply you data set quarterly.
Okay, but then should I document the follow-up first, or no, or just the third one?
What do you mean the third one?
So when I follow with the patient in a month, should I document that TMR?
Yes.
Andrew doesn't have to give me the paperwork. But.
Yeah, so ideally, even if you don't have paperwork, so remember our TMRs are not dependent on the paperwork. We'll go with the most recent paperwork that we have from the clinic. So if you're doing a TMR in July and the most recent data you have is, or you're doing a TMR in June and the most recent data you have is from April, that's fine. Go ahead and meet with the patient. Obviously, we want to have the most recent data that we can. but trying to stay on that schedule of every 3 months with the patient. And every TMR that you deliver to a patient should be documented in the data collection tool and sent in.
Okay, but just on the data collection tool, not on the...
Well, the clinic's doing the form, so you shouldn't be filling out those quarterly forms on the pharmacy's end.
Right. Yeah. Okay.
Amber, this is Ashley. So if we have, because I have a few patients that I haven't, their quarterlies were due like 2 months ago and they've kind of fallen off the face of the earth.
Sure, yeah.
How exactly are we to go about documenting the fact that the only reason that or if we say they fell off the face of the earth for 2 months and then we got in touch with them, how are we going about documenting the fact that the reason their TMR wasn't done on time or was late was because we were unable to get in touch with them?
So you can document it in your interventions within the TMR and the data collection tool, and also on that patient information tracker, there's a spot for the date of the TMR, and if the patient doesn't show up at all for the TMR, if you skip a quarter, you can write no TMR in there.
I'd say we can. I know it'll let us type in stuff on there, so I didn't know how that would work when they extract that, if it had to be actual numbers. So I can actually write it.
Oh, so you're saying like write a note about that patient?
Like I had on the spreadsheet we filled out, I had like a few people that were unenrolled because like somebody passed away before their TMR or they moved away, and I had typed in there, like I had their CMR date, and on their TMR I put under there unenrolled, or can I put on there no TMR done because unable to
just write no TMR, and we're going to assume that it's not because the pharmacist didn't want to meet with the patient, it's because the patient didn't show up or wasn't able to be reached or whatever reason.
Okay.
Great question. Just quickly, we are nearing the end. Yes.
Hi, Michael. It's Christy from Care Resource. How are you?
Hi, Christy. How are you?
Good. I just have a question about the TMRs as far as the clinic is concerned. So you said that we fax over the TMRs to you for every quarter, as well as we give it to the pharmacist whether the patient comes in or not, right?
Correct.
Okay, so how exactly do you guys keep track when the patient comes in? Is it by the dates that we put on the Health HIV log that we send to you? Or do we scan what Walgreens sends to us as far as TMR?
Hey, Christy, this is Ambrose. Can I ask a quick question before you answer, Michael?
Sure.
When you say how are we keeping track of when the patient comes in, are you referring to whether or not they come into their pharmacy appointment?
Right, yeah.
So our pharmacists are keeping,
TMR.
to do the TMRs. Our pharmacists are keeping track of that and those dates that they come in. And they're sending that in to us here at corporate at Walgreens.
Okay, because the reason why I asked is because it is a question that it is in the log that we have to send to Michael Schenkel as well. So I just want to make sure if that is how Michael and your team and is keeping track of how we're doing with our patients in the TMR. Am I being clear? I mean, I don't know.
Yeah. So the sheet that you are submitting weekly to us will show a quarterly visit or a TMR visit. You should note that should be the number of forms that you have sent to us.
Okay. Okay, I just want to make sure that what we have is what you have at the same time. I don't want,
Yep.
Okay, good.
Yep. I understand your question.
Okay.
Kristen, do you want to talk briefly about your poster?
Hi, sure, yes, I can. Just quickly, because I know we're out of time. So on behalf of the team, I've put together a poster titled Implementation of a Patient-Centered HIV Care Model to Optimize HIV Outcomes Through Improved Communication Between Pharmacists and Providers. It's a mouthful. But this will be presented at the end of June at the International Conference on HIV Treatment and Prevention Adherence. So we're pretty excited because I think it's one of the first abstracts and posters for the project. And the main focus of it is just to describe the the model and describe the implementation process, including some of the early challenges and early successes. So some of the early recruitment challenges and then also some of the early successes that you have all been identifying for us during the weekly calls. When we submitted the abstract, it was the end of January. So at that time, only 114 patients had been scheduled. So it's not heavy on patient data, but it describes the model and describes the implementation process. So it's a good way to get some early traction and communicate what's going on at the sites. So once we get a final copy of the poster all put together, we'll definitely send it out to everyone. And hopefully it'll also just help you to brainstorm and get some ideas for future abstracts, because not all abstracts have to have clinical data. A lot of it can be implementation science and describing the processes that you're taking to get this model up and working at your sites. So stay tuned.
Thank you, Kristen. And I just wanted to end with, again, a big thank you for all of your hard work. You guys are doing a tremendous job, and we're looking to hit that 1,000 patient mark by the end of June. So we appreciate everyone's diligence in helping us get to that point. I did want to mention that we are going to be scheduling site visits with sites over the next several months, so you can anticipate hearing from us about a site visit at your location coming soon. Any other last-minute questions or comments? Thank you all so very much. I appreciate it, and we'll talk to you in a month.
Thanks. Bye.
Bye-bye.
Thank you.
Bye.